discuss today. Again, thank you to everyone for staying through the last session of the meeting. I'm going to discuss today the use of desmetorexis alone as a treatment for Fuchs dystrophy. I have no financial interest in anything I'll be discussing. And as Dr. Sarnicola gave us a nice review yesterday of the corneal endothelium, as we know, it's a monolayer of hexagonal cells that's derived from neuroectoderm, and I believe that that fact is going to be important in determining the underlying pathophysiology of Fuchs dystrophy. These cells in general do not divide after birth, although they can be stimulated to divide in the lab by the use of growth factors or adenoviral vectors. They're halted in G1 phase of the cell cycle, and they're contact inhibited, meaning once the cells reach their neighboring cells, they stop moving. And we know that they maintain the deturgescence of the cornea by both passive barrier function and active ATP requiring pumps. Fuchs dystrophy, described over 100 years ago by Ernst Fuchs, was originally determined to be an epithelial disease, and it wasn't until about 10 years later that the role of the corneal endothelium was determined. It's a slowly progressive dysfunction of the corneal endothelium, which results in both pleomorphism and polymegathism of the cells. Typically diagnosed in the 40s, the disease often does not require intervention until the 60s or the 70s. Women are more commonly and severely affected in Fuchs dystrophy, and the reason for that is incompletely understood. Of my practice in Boston, approximately 1/3 of patients had a known family history, and it is the most common cause of corneal transplantation in the United States. Goutte are very relevant to the pathophysiology of this disease. They're shown here. They're excrescences within and on bone Descemet membrane, and they're shown in electron micrograph here. We know that it's very common to have Goutte. Up to 4% of patients in the U.S. have them, and they do cause disruption in vision by scattering of the light rays. And this is shown quite nicely at the end of 2015 in the journal Ophthalmology. So we know that corneal transplantation has undergone a revolution. Many of the people in this room have participated in the progression of this condition. No longer do we do penetrating keratoplasty, and endothelial keratoplasty is really state of the art. But several lines of evidence suggest that even this might not be necessary. Professor Sarnicola reviewed this study from Garrett Mellis, published in 2012, describing DMET, or Descemet membrane endothelial transfer, and this is essentially a failure of the DMET graft to adhere. And interestingly, this group showed that patients with Fuchs dystrophy could clear their cornea despite detachment of the endothelial graft, whereas patients with bullous keratopathy did not. Similarly, a case study from Shigeru Kinoshito showed that application of cryotherapy to a Fuchs dystrophy cornea followed by a 7-day therapy with a ROCK inhibitor resulted in corneal clearance and repopulation of the endothelial mosaic. However, even Shigeru admits that he did not do the control of simply cryoing the cornea and seeing what would happen without the ROCK kinase inhibitor. And then finally, besides the case report that Professor Sarnicola reviewed yesterday, there is this case report from Steve Koenig showing an inadvertent desmetorexis during resident-performed cataract surgery where the cornea cleared and the patient maintained good vision for many, many years. So I was aware of all these studies when I attended the 2013 EU cornea meeting and sat to hear Gabriel Van Rie give his medalist lecture, where he described a series of deliberate desmetorexis in a small number of patients. And his results were not great, but the combination of these facts led me to try deliberate desmetorexis in my patients. I picked my index patient carefully. A long-term patient of mine, an attorney, He understood the concept of practice of medicine, physicians doing novel, unproven therapies in the best interest of an individual patient. Shown here is his preoperative confocal microscopy demonstrating no central endothelium and a thickened pachymetry of over 650 microns. He had maintained peripheral endothelial cell counts. I performed phacoemulsification and then a 4 millimeter decimetalrhexis after the IOL was placed. His cornea was swollen on the first day and the first week after surgery, but by month 1, he came in telling me that things had cleared up quite dramatically, and shown here is his confocal from his month 1 visit, demonstrating an intact corneal endothelium and a reduced pachymetry with improved vision. This is his month 15 appearance, showing the edge of the decimetalrhexis and a preserved endothelial mosaic of approximately 900 cells per millimeter squared with a Dieter chest cornea and 20/20 vision without correction. And I will point out that these are his own cells. He followed me to Chicago, where I saw him in January of this year, 2 years after the initial surgery, with a maintained endothelial mosaic, a stable pachymetry, and excellent vision. And he has given me the permission to share this photograph of him. So I waited about 10 months to make sure that something bad wasn't going to happen to this man's cornea, and then performed this procedure on 12 eyes of 11 patients. The 13th eye was completed by one of my colleagues after I left for my chair job in the University of Chicago. There was a wide age range from 51 to 91. Most were women, not unexpectedly, and 2 of the women had bilateral surgery. Of this cohort, 3 did not respond. They showed no clearing of the corneal edema or movement of the endothelium, and had uneventful endothelial keratoplasty. This paper is just out online in Cornea this last week. 4 eyes in this group cleared within 1 month, which I termed rapid responders. An additional 4 eyes cleared within 3 months, and then 2 eyes cleared more slowly, but were improving at each visit, and the patients were happy to continue observing, and they eventually cleared without any evidence of corneal scarring or reduced vision from a corneal reason. And shown here is a montage preoperatively at month 3, the endothelium and the clinical appearance of one of the women who had bilateral surgery. So of the eyes without pre-existing macular pathology, all eyes that responded obtained 20/20 vision. The mean pachymetry was 567, and the mean cell count was approximately 700. There was no correlation with age, smoking status, or diabetes. These are all factors that are known to increase the oxidative stress, which we know is an important factor in the pathophysiology of lupus dystrophy. However, 3 of 5 patients with a preoperative pachymetry of over 625 microns were in the failure to clear group, and thus this may represent a risk factor for failure to improve after this procedure. And the genetic analysis is actually complete, but due to the sake of time, I will not review that. Other investigators have done this. Greg Maloney from Sydney, Australia, has a series that is showing similar results. Of course, there's no rejection because there's no foreign cells, and no need for long-term topical steroids, which even in DMEC have a risk of rejection of up to 6% if steroids are stopped. So the disadvantages of this procedure is early in its infancy, it does not work in all patients, and widespread acceptance will only come when we have a better understanding of which patients it works for and which patients it doesn't. Remaining questions include the optimum size of the decimetalrhexis, the amount and duration of postoperative topical steroids, and certainly if we had a Rho kinase inhibitor available to us, this would speed cell migration. Now, it's interesting to think about why this works in Fuchs dystrophy, and I've spent a lot of time over the last several months actually reviewing literature not only in cornea but in the other neurodegenerative diseases. And this is my working hypothesis for the pathophysiology of Fuchs dystrophy. I believe at the center lie the mitochondria and the mitochondrial-associated endoplasmic reticulum, and we knew at this point 20 years ago that mitochondria were involved with this disease. But you can see here there's multiple different genetic pathways that get us to Fuchs dystrophy, and we need to really at this point step back and try to think of a hypothesis that can be tested to determine exactly what the pathophysiology is, because when we know that, then we'll be able to design non-surgical interventions that may help in the early stages of this disease. And specifically interesting is this idea of RNA toxicity and translation of these RNA products into aberrant protein products. This is known to be an important factor in all other neurodegenerative diseases that have the nucleotide repeat expansions as part of their pathophysiology. So please stay tuned for more on this in upcoming meetings. So we've seen amazing advances in our understanding of this disease over the last 20 years. There's certainly tremendous advances in surgery. We know desmetorexis can work in certain patients. More work is needed, and it really causes us to rethink the biology of this disease. It's been a pleasure for me to stand among my friends and colleagues, many of whom are shown in this photograph, as we explore this fascinating disease. Thank you.
Dr. Kolby, just a moment. It's a new thing about endothelium, but can you repeat for us which are the clinical characteristics in which patient we can try to do the rexis without replacement?
So for right now, I would say you probably want to aim for patients who have a pachymetry less than 625 with primarily confluent central guttae and a preserved endothelial mosaic.
Thank you. Thank you so much.
You're
That's
very
very interesting compliments. And so,